Hi, this is Katie Williams. I am a pediatrician at the Ferlato Center for Complex Pediatric Care in Greenville, South Carolina, part of Prisma Health Upstate. Today, I'm going to be talking about telemedicine, going the distance for children with medical complexity. This presentation is and presents part of a study that was submitted by myself, Dr. Kent Jones, Dr. Bob Saul, Dr. Carly Howard, Dr. John Markowitz, Lisa Capera, and Karen Driggers. 21 months ago, our pediatric complex care clinic was approached by our vice chair of quality about developing a telehealth program to serve our patient population. Our clinic had not been searching for an out-of-the-box way to use more technology in our practice, but 12 months after our first meeting, we completed our first telehealth visit. This is our story of implementation, outcomes, and lessons learned from telemedicine in our clinic. Because of COVID-19, it is actually a tale of three versions of telemedicine. To understand why telehealth is an attractive option for children with medical complexity, you have to understand who this patient population is. This is one face of a child with medical complexity. It's hard to see her in the picture on the right, but this remarkable young girl is descending from the ropes course she just completed at our complex care camp last year. Children with medical complexity are a diverse group, with many different underlying medical conditions and healthcare needs. Clearly defining such a heterogeneous group of children has been challenging. In 2016, the American Academy of Pediatrics published an article to do just that. They begin by defining a much broader group of children termed children with special healthcare needs. Children and youth with special healthcare needs include children with medical complexity, but also others with diagnoses as diverse as ADHD, asthma, chronic depression, and foster care placement. This group represents about 15% of the 76 million children in the United States. Children with medical complexity, who may also be known as complex chronic or medically complex, have multiple significant chronic health problems that affect multiple organ systems and result in functional limitations, high healthcare use, and often the need for medical technology. Medical technology can include feeding tubes, tracheostomies, ventilators, or VP shunts. They see many medical specialists, frequently more than 6. There are substantial effects of their healthcare needs on their family unit. Children with medical complexity represent less than 1% of children in the U.S. Every payer and large health system across the country is looking towards this growing population, and this is why. Less than 1% of the population of U.S. children is estimated to account for a quarter to a third of pediatric healthcare spending. And there's great cost to families. These families have every aspect of their lives affected by their child's condition. This is a care map created by the mother of a child with medical complexity to pictorially represent aspects of her child's life. 54% of families had a family member stop working to care for their child. And this is all in addition to the challenges that families across America experience every day, including a poor support system, financial difficulties, and access to care issues. A felt need for many of our patients' families is transportation. Families may lack gas money or a vehicle. Some children require two-person transport due to their fragility, and some require transportation on a stretcher and an ambulance. This is an example of the equipment a child with a tracheostomy would require whenever he leaves the home. You can see there are emergency supplies, a suction machine, oxygen, an oxygen monitor, and health records. This does not include feeding supplies such as formula and a feeding pump and syringes for the feeding pump, or basic things like diapers and a change of clothes. Non-emergency medical transportation is a required benefit for patients covered by Medicaid. either through reimbursement of mileage or through direct transportation by a Medicaid vehicle or a contracted ambulance. It can be a cumbersome process, requiring phone calls and approvals. The visit has to be arranged and approved 72 business hours in advance of the visit. So taking your child to a same-day sick appointment for an illness is off the table for many families. Those families are faced with the decision to call 911 and be evaluated in the emergency department or go without a medical evaluation at all. The estimated annual expenditure for non-emergency medical transportation is $3 billion. This is where our clinic is located, the Ferlato Center for Complex Pediatric Care. The yellow cross is our clinic, which is in Greenville, the city of Greenville, South Carolina. And each red star represents a general location of some select patients' home addresses. The circle is an approximate 30-mile radius around our clinic. And as you see, a good number of our patients are over 15 miles from our clinic, and some live over 30 miles from our clinic. While we're in Greenville, they may be in Walhalla, Seneca, Honeypath, Fairplay, Greenwood, Clinton, Lawrence, Spartanburg, Boiling Springs, and even Blacksburg. And while as a primary care clinic, in addition to seeing kids for checkups, we also see them for sick visits, so they have to get here sometimes on short notice. In the end, the real dilemma was not whether telehealth is implemented, but how. When we began these visits, telehealth office-to-home visits were not reimbursable by insurance in the state of South Carolina. The study sponsor and funding for the study is provided by the South Carolina Children's Telehealth Collaborative. The Children's Telehealth Collaborative operates through the South Carolina Children's Hospital Collaborative and in partnership with the South Carolina Telehealth Alliance to facilitate the development and operation of collaborative telehealth programs benefiting children throughout the state of South Carolina. Many children with medical complexity in our state are serviced by a Medicaid waiver called the Medically Complex Children's Waiver. And our study initially really hinged on collaboration with this waiver. The waiver provides community-based nursing care coordination. It provides a per member per month for primary care to support non-billable work provided in the care of a child with medical complexity. And it's available in every county in our state. The criteria for the waiver align with the criteria for acceptance to our clinic, the Ferlato Center for Complex Pediatric Care. So this ultimately will be a tale of three versions of telemedicine. Prior to COVID, we started using this TytoCare-based telemedicine that was part of our study in the home of children in November 2019. As part of their program, waiver nurse care coordinators conduct in-person assessments quarterly called team conferences that typically occur in the home setting without the involvement from medical providers in real time. They make a summary from the team conference and they fax it to us after the fact. For our study, a memorandum of agreement between Prisma Health and South Carolina Solutions allowed the waiver nurse to act as a telepresenter for the quarterly team conference. 3 waiver nurses were trained and equipped with a handheld examination kit purchased through TytoCare that included a stethoscope and otoscope. The device is paired with an Apple iPad for wireless network transmission of a live video visit via a HIPAA-compliant web-based platform called Video. It's spelled V-I-D-Y-O, Video. All visit charting by the Ferlato Center team was performed in the electronic medical record, which for Prisma Health is Epic. When COVID-19 pandemic prevented waiver nurses from entering the patient's home, we transitioned to telemedicine through our electronic medical record, just as many providers across the state did during shelter-in-place orders. And these visits are still ongoing. We are now working on disseminating home-based TytoCare care kits to select families for the caregiver to act as the telepresenter. The main difference between the electronic medical record-based telemedicine through Epic and MyChart and the TytoCare-based telemedicine is the exam capabilities. Our goal for this study was ultimately to determine if a home-based telehealth appointment is equivalent to a traditional office visit for routine follow-up medical appointments for a child with medical complexity. We've broadened this a little bit to include acute care visits now. We tracked satisfaction data from caregivers, physicians, and care coordinators. In addition, we wanted to determine if the telehealth visits were able to provide the information needed to support medical decision-making by the team and whether any cost savings are demonstrated. We assumed the biggest cost savings would probably be based on transportation. In summary, we wanted to know if telemedicine was feasible, and if we're going to do it, we want it to be quality. This is a picture of the TytoCare exam equipment. The handheld device acts as a camera for a skin exam and throat exam, and there's an infrared thermometer. It has 3 attachments, an otoscope for ear exams, an attachment to auscultate heart, lungs, and abdomen, and a tongue depressor to assist with the oral exam if needed. The physician directs the telepresenter to place the device where needed through the device itself, the kind of computer device interface. This was our original workflow for the telemedicine study. I won't belabor this, but having it planned in advance when you're working through a new process did truly make scheduling go a little bit easier and the visit flow more smoothly. So this is a screenshot of the physician computer screen during a telehealth visit. On the left, in that web browser, you can see an example of the skin exam provided by the TytoCare. So that is through the web-based TytoCare browser. That's what you're seeing through the little thing that nurse is holding up to the child's patient. On the right is the video display through the iPad that's usually set up to see the caregiver, patient, and the waiver nurse in the home. And so you see there's 2 screens here then. The TytoCare for the exam and the video, VIDYO, for being able to see the patient and the patient's caregivers and nurse. What's not visible is there's also a browser somewhere with the electronic medical record that the physician documents in. In our newer version of this, using TytoCare in the home without the waiver nurse, with just the families presenting the patient, the video component is actually embedded in that web-based TytoCare screen. And so it does eliminate one extra web browser, which helps. So by the time COVID came around, we had completed 10 of these team conferences using the TytoCare telemedicine platform. These are the provider satisfaction scores we collected, and as you see, the scores were generally good. There was a kind of short, low-inclined learning curve for the physicians to adjust to the technology and documentation needs. Physicians did note it. They seemed acutely aware of the benefit to the patient when even they were filling out their own satisfaction scores. And physicians noted that one parent didn't have to take off work. Remember, the providers are being asked how satisfied they are with it, but they noted that one parent didn't have to take off work. Another did not require assistance for the visit transportation since the single parent was recovering from a heart attack and just having had a heart cath. So we were tracking also whether telemedicine supported the medical decision-making, and we found that while these were scheduled follow-up visits, they were planned well in advance, weeks in advance, that 5 of the 10 visits had an acute issue that required it to be addressed during the visit. And you can see that of those 5 things, that acne, a G-tube infection, a cold, and wheezing were the ones that were listed in the information gathered. So of those visits, of the 5, 4 of them provided the needed information to address the acute issue, and no visits resulted in a subsequent office visit or ER visit. The one that the provider did not feel it supported the decision-making was the inability to get a good ear exam. So there certainly are limitations to the visits. Inability to obtain an accurate weight was an issue noted. On surveys, our patients are often fed specialized diets by feeding tube, and maintaining good nutrition is key to good care. The second was the ear exam. It was limited by the presence of earwax or expertise in positioning the otoscope properly in the ear canal. Strengths of the exam equipment included very good lung exams with documentation of wheezing heard, as well as excellent skin exams. Our patient and caregiver satisfaction scores really speak for themselves. The only two comments made by caregivers were that those two caregivers felt the exam may not have been as good as the office visit because they perceived the ear exam was challenging. They could, I guess, tell on their end that it wasn't going well. And there were other benefits. 8 of 10 caregivers reported money was saved by doing the visit this way as opposed to coming to the office. 10 of 10 caregivers reported there was time saved, and 4 of 10 caregivers reported avoiding lost work. As mentioned previously, transportation to medical appointments is a benefit paid for by Medicaid, either by reimbursement for mileage in a private vehicle or in a Medicaid van or contracted ambulance. Of these visits, 2 of them would have been performed by ambulance transport. The patient required stretcher transport. And so the cost savings for this were 88 miles per patient per visit saved of those 2 visits. The remaining 8 visits, the families would have transported the patient by private vehicle, and the distance from our clinic ranged in miles from 5 miles to 42 miles. So this was a savings of 16 miles per patient per visit that was saved that would have been reimbursed by Medicaid. So we are now living in the midst of a worldwide pandemic that no one living has lived through before. COVID abruptly ended the in-home team conferences and impacted many aspects of how we provide medical care. We were disappointed, but quickly found that COVID changed the way South Carolina did telemedicine. Insurance providers quickly adapted to the need to shelter in place and began reimbursing for these services on a temporary basis. We quickly learned to perform telemedicine visits through Epic MyChart through the Prisma Health Upstate system. These visits afford our families ongoing medical care from the safety of their home. A big distinction is that the exam is limited to what can be examined by just a video. Having experienced both platforms, the video quality through the electronic medical record system can be finicky, and the skin exam or examining anything that requires some detail a little challenging. The satisfaction scores you see here are from Press Ganey surveys submitted from across our pediatrics department as a whole. These are not just from our clinic. The lowest noted are for ease of scheduling and the audio connection. So we began to work quickly on transitioning to our third way to provide telemedicine to our patient population. We are transitioning the telepresenter from the waiver nurse, as we started, to the parent or caregiver in the home. Knowing the limitations now with the Epic MyChart telemedicine, we were looking for ways to improve the examination capabilities for some of our high-risk patients. We resubmitted a new IRB last month and secured 20 home-based TytoCare kits for our high-risk patients selected by the physicians in the group. We completed the first one of these visits last week. The technology performed well, and the visit was for an acute illness of a hospice patient on a ventilator at home. Transportation for this patient is difficult and requires either 2 skilled, trained people in tracheostomy emergencies or an ambulance, which takes 3 days to secure. I personally completed the visit. Of course, the ear exam was impeded by wax, but I felt comfortable that the visit supported my medical decision-making and prevented them from coming into the office. So I look forward to continuing to improve how we use telemedicine. In summary, home-based telemedicine using handheld examination equipment is feasible. It generally supports medical decision-making. It affords high satisfaction from physicians and caregivers. It results in savings to the payer in the form of transportation costs. It results in time and money saved for caregivers with high emphasis on convenience. I've learned a lot about telemedicine implementation over the last 11 months. The technology performed well through TytoCare. Background noise was surprisingly not a major issue. Headphones helped during the exam portion. The electronic medical record-based telemedicine had some issues with audio-video connection. The exam equipment performed better than expected, but ear exams remained a challenge, even with the nurse as a telepresenter. There's going to be limitations with things like obtaining a weight and certain vital signs, such as a blood pressure. There will always be certain complaints or situations for which telemedicine is not appropriate. Being aware of the limitations to the telemedicine visit and appropriately triaging those to the office will be important going forward. We had the benefit in the initial pilot study of each nurse having a MiFi paired with a new iPad. And there's a lot of rural areas in our state, and having reliable wireless may be a challenge. So some of the good audio-video connection we had in the initial study may have been related to the good access to wireless based on having this MiFi or hotspot. Some of the issues that we've seen with the EMR-based telemedicine that relies on the family's wireless that may be contributing to the audio-video quality. And that really remains to be determined. So we may see more issues with wireless access as we go. General access to a physician and medical care was an issue in the first study. The visit only took place under very specific planned circumstances and was limited to about 2 to 4 visits a year per patient in this way. So coordination between the case manager and the physician was improved, but access remained an issue. And so having caregivers in the home as the telepresenter, we expect this to improve. It can be used for scheduled visits, and it can be used for acute care visits. As we perform more telemedicine visits, it'll be helpful to track whether it resulted in a subsequent office visit or ER visit. This is especially true for the acute care visits that we will be performing. We need a more permanent ongoing payment model for these visits. We need to continue to fine-tune the patient population who will most benefit from this technology, especially the technology that uses examination equipment. In our group of patients, our hospice patients, ambulance transportation, significant distance, high emergency department utilizers, newly complex, or new to foster care are all felt to be good candidates. I would like to open up this time now for questions that I might be able to answer. You can consider directing them to the chat box, and I will be available. Thank you.